This is jointly sponsored by the University of Oklahoma's Oklahoma Primary Healthcare Improvement Cooperative and the Oklahoma Department of Mental Health and Substance Abuse Services. And to start us off today, we're very honored to have Carrie Slatton-Hodges. Ms. Hodges became the interim commissioner of the Oklahoma Department of Mental Health and Substance Abuse Services in January 2020, following the departure of Terry White, who had been the commissioner since 2007. Ms. Slatton-Hodges had served as the deputy commissioner for 12 years before stepping into the top job. She has been a licensed professional counselor for 29 years with a career that has taken her through a wide range of settings and roles. She grew up in Oklahoma City from the age of 13 on and graduated from Putnam City North High School. Ms. Slatton-Hodges completed a bachelor's degree from Southern Nazarene University and then moved to a farm in western Oklahoma, just east of Bessie, on the West Washita River. While there, she obtained a master's in applied psychology from Southwestern Oklahoma State University in Weatherford while raising Angora goats and alfalfa. She started her work in mental health in rural setting, covering 8 counties, and developed, and supervised almost all types of behavioral health programs. She believes she was born a counselor by nature and was raised by very intelligent parents who also strongly believe in giving back to society and to those less fortunate. She also believes that one of the best things in life is to see someone go from being very ill and to be around to see them at their best. Commissioner Slatton-Hodges, if you will.
Thank you so much, everybody. And it's so great to be here today. You know, technology is such a strange thing. I'm actually at the Healthcare Authority today. Kevin Corbett allowed me space here. But as I'm sitting here, they have the type of lights that go off when there's no movement. And so now I'm sitting in the dark. But I have my slides here. Hopefully I'll be able to share with you and you can see everything well and can hear me well. So the main things that we want to talk about today, I think, is kind of what our service system is like across the state and how you might best be able to link people to that whenever needed. Oh, okay. I'm not even going to try to go back. Let me try one thing. There we go. Fund and operate a statewide network of behavioral health treatment providers. And basically there's a couple of different types of providers within that system. One group is providers that we contract with and that we work very closely with around the state to help develop what their delivery of care will look like. We have rules and contracts that kind of guide what services will be available, what kind of time frames around those. And then we have services that are operated by the state, and that the state actually operates for community mental health, crisis units, psychiatric hospitals, etc. We also oversee the Medicaid behavioral health policy and the management of those funds for behavioral health services. So through this, we have everything from outpatient services, urgent cares and crisis centers, hospital care, substance abuse treatment options, court-related services, jail diversion programs, services that are embedded in our prison system, forensic services, prevention services, as well as certifying providers, helping with transitions of care and specialized housing needs. And you know, like all medicine, behavioral health has actually rapidly changed over the last 50 to 60 years. At one point in time in our state, which is true around the country, the majority of persons who had a mental illness or were designated to have a mental illness, sometimes they didn't have one, they lived their life in institutions. They would go to a large psychiatric community and live their entire lives there. Sometimes they would marry there, sometimes raise children, and that became the entirety of their life. So in Oklahoma in 1960, there was approximately 6,400 Oklahomans that was their experience. We had 3 major hospitals, one which was up in the northwest part of the state, Fort Supply, as you may know. We had one in the eastern part of the state, Eastern State Hospital, and then one in Norman, which was Griffin Memorial Hospital. All of those were large facilities, lots of housing. They actually farmed, they raised livestock. They were basically towns for persons with mental illness. In 1963, the Community Mental Health Center Act was passed, and it was really a result of President Kennedy, who had a sister who struggled with multiple conditions that affected her behavior and her thoughts and emotions. And what he found throughout his life was that she was not able to live with the family the majority of the time. She lived in institutions, and it was his desire for people to be able to remain at home, but be able to receive the care that they need in the community where they live. And so the Community Mental Health Center Act was passed, and with that was a desire to start building a network of services within communities, so that the only way that a person could receive treatment would no longer be by going to an institution and living their life there. Oklahoma has an interesting first in that Central Oklahoma Community Mental Health Center in Norman was the first that was built with those Community Mental Health Act funds. And so that facility was the first built with those funds in the nation. What we know nowadays is that there's actually a relatively small percentage of persons who have mental health issues that require hospitalization. Because of having services in the community, most people are able to start their journey to treat symptoms and start their journey of recovery much earlier than they would have in the past. So people who may notice that they're sleeping too much, or they're feeling hopeless, or they don't have motivation, actually can reach out at a much earlier point, start to get care and treatment, and never need to have care in a hospital. Another initiative that has happened both in behavioral health and physical health is the use of telehealth. And Oklahoma's behavioral health system was recognized as being the most advanced telehealth system in the nation for behavioral health as early as 10 years ago. So it is something, by virtue of being a rural state, that we have always had to make great use of. A rural state who also oftentimes did not have the psychiatrist ability to be everywhere all the time. And I can remember the days when a psychiatrist working for a community mental health provider would treat or see patients at one location in the morning and then drive an hour and a half to get to another location to see and treat persons. Nowadays, that most likely happens through a psychiatrist being in an office and seeing people at the more remote locations through the use of telehealth. We also have a greater wealth of medications in our more modern times than we did years ago that can truly assist with mental health and addiction disorders and to help people stay in their communities to receive care. I wanted to talk a little bit about some of the kind of additions to our system over the years that have been helpful additions and helped people remain in their community. So one on the outpatient side is we have requirements for our community mental health centers that they must follow. And one of the ways that they are paid is not necessarily through a fee-for-service basis. They receive a portion of funds on a fee-for-service basis, but the majority of their funds are received through or exceeding benchmarks that are set by the department. One of those benchmarks, for example, is that if a person is seeking services, whether or not they can have a face-to-face visit within 3 days. So we have that expectation, and they get paid only if they meet that for the majority of people seeking care. We also have benchmarks that must be met in order to be paid around things such as if a person was involved in a crisis situation, say they had a crisis call or they were seen face-to-face in crisis, that person will have a reach out again after that crisis to make sure that things are going well, that they have started to engage in care to prevent a crisis from happening again. And then also, if people are leaving our state system higher levels of care, such as our psychiatric hospitals and crisis units, that they have swift engagement with community providers. We also started what are called comprehensive community addiction recovery centers. And those are centers similar to community mental health centers, but on the addiction side. So they have everything from case management, peer services, crisis services. They can evaluate and provide medication whenever necessary, as well as a large array of outpatient care for individuals needing addiction treatment. Urgent cares are something that we layered in about 7 years ago, probably 8 now. And used to, when a person was having difficulties and they went to a crisis center, for example, and I'll use Oklahoma City as an example because this is a very concrete example. When you went to the crisis center in Oklahoma City, what happened is, and this is whether you came in yourself, whether you came in with law enforcement, whether family brought you, you basically got a yes or a no. Yes, you meet criteria to go into a bed, or no, you do not. What we added was an urgent care. And what that urgent care does is that it doesn't matter if you meet inpatient criteria or not. If you are to the point where either your family or law enforcement or yourself is reaching out for help, then we want to provide you that help. So you can come in and receive care immediately, 24 hours a day, 7 days a week. And then at the end of a period of time, usually less than a day, if continued care is needed, then you would move on into an available bed at that point. But what we have found is there's a large number of people that when they can receive care 24 hours a day, don't ever need to go into a bed. We can provide case management, we can provide medication, you can see a therapist, and then we can link you to those services ongoing. And then hopefully you would not have to move into a hospital setting. And the reason I say that is that not that hospital settings are not good and not that not lots of people need them, but that there is a trauma that goes along with being removed from your community, being placed in a facility, not able to interact as easily with your support network, and then having the discharge process go along with that. So that if we can prevent that and we can provide you the care you need right then and there and continue with outpatient, it's better for the person served, and it allows us to treat so many more people in crisis. And then our crisis centers are where if a person then does need some time out of the community and more intensive treatment, we can do that on a short-term basis without needing to go on to a hospital stay, which is oftentimes longer. So you can kind of think of a funnel with the widest part at the top being urgent care. So we can treat you there. If that is not enough, it narrows a little bit more and we can treat you in the crisis center. And then if that is not enough, you go further down that funnel and we have hospital services for you at that point in time. So this is a map of the community mental health center regions in our state. These have changed a little bit through the years, not the actual regions per se, but sometimes we have blended providers to serve larger portions of the state. For example, where you see that light blue up in the northeastern part of the state, that is a Grand Lake Community Mental Health Center. They used to have about half of that region. And a couple of years ago, we did an RFP for the more western portion there, in which Grand Lake then became the provider for that portion as well. And we've seen some really good things come from putting that out to bid and bringing in a new provider. These are where our comprehensive community addiction recovery centers are located. This, in essence, was a voluntary program by which, if you wish to be certified as more than an addiction treatment provider, and you want to step up the game and make sure that you have all of the holistic services that we feel like are best for persons in addiction, then you can seek that certification. And these are where persons have sought that certification. And those are where we tend to provide our most training and guidance and evidence-based practice work, is to continue to lift those up to be the very best that they can be. This is where our crisis centers and urgent care centers are around the state. We actually have the ones that you see up towards the northeast are newer. When we did that RFP switch, then we've opened some urgent cares up in that area. And then I want to talk a little bit about how you can connect somebody with behavioral health services when you need to, and maybe the best ways to work around trying to connect people to care. So as I mentioned, we have contracted and state-run facilities around the state. You can go to our website, which is odmhsas.org, and you can find providers that are close to you. We have added a portion to our website that is our agency's network of care, and that you can enter by city, by county, by type of services, by zip code, and you can see what is available in your area and how to connect with them. And when you think, well, who would be eligible for those services? Anybody who really does not have the ability to pay is available to receive services from our network. In addition, we have sliding scales for people that fall above 200% of poverty. Most of our providers take various types of insurance. Virtually all also provide Medicaid compensable services. And we'll talk a little bit about the basic steps for a great referral and the best case scenario for follow-up for that as we move along. One of the key thing that I want to say about that, and we can talk about this a little bit more later, is that, in my opinion, the best way to help persons that you see connect with behavioral health services is to identify the treatment locations that are near you, which you can do from our website, and then to reach out and develop a relationship with those providers, to talk about when you might need care, what kind of work you do in case they would like to have a reciprocal referral situation, what the easiest way for you to do that specifically with that agency. Usually they'll give you a point person to call, to talk to whenever you have a situation. And so I always feel like those personal relationships are absolutely the best way to go. But there definitely is all of the information you would need on our website. So one of the things that we do know is that treatment works. There is lots of data around persons who receive behavioral health treatment and the positive outcomes of that. People can and do get better every day around mental health disorders and addiction. But what is a key component to our entire system is prevention, because preventing someone from becoming ill or having symptoms that interfere with their daily life is the best thing we can possibly do. So the department works with healthcare agencies in support of numerous behavioral health prevention programs. One of the ones that is most commonly known and referred to is SBIRT, which is Screening, Brief Intervention, and Referral to Treatment. And we have more than 18,000 patients across our state that have received SBIRT services. And I want to take just to talk about that because I think SBIRT is so incredibly important. And I would ultimately love to see it at every healthcare providing agency, whether that be ERs, primary care offices, hospital settings. It is so key as a preventative tool. And what it does, if you're not familiar, is there is a screening that identifies the substance use and the alcohol use of the person that you're interacting with. And it lets you know whether they are in a normal range, a moderate range, or really a dependent range. And then you can have that conversation with the person about what their current use is, how that is affecting they and their lives, and what normal use, say, for example, of alcohol would look like. And what we have found is those persons that are in that moderate range, so they are on their way to becoming a dependent person. By having that discussion of what normal use actually looks like, that they are at risk of developing a dependency based upon the current use that they have, that conversation has the ability to tip a person back into the normal range, thus preventing a person from becoming dependent upon substances, and then ultimately the damage that comes with that and the treatment that is needed for that to help them put their life back together. And that's why I think it is such an incredibly important initiative. We literally are preventing people from becoming dependent upon substances by screening them and having a brief intervention with them. Now, there are persons during an SBIRT interaction that are identified as dependent. And that is then where the referral to treatment needs to come into play. But when you use SBIRT as a universal screening process, what we find is that we are able to touch so many people and tip them back from becoming dependent that it has an amazing result on our state and on our dependency rates by having a statewide network of SBIRT. I have a zero suicide initiative that falls on two different sides. It falls on our treatment side and it falls on our prevention side. And on our prevention side, we work with health systems across the state to really be able to have conversations with people and provide training and technical support around that to identify when persons are at risk and to identify when they need to be connected to a provider to address that risk. Suicide is somewhat similar to SBIRT in the way that if we can identify a person before they're at a crisis state, that they're having thoughts or they're feeling hopeless, then we can start to work with that person and prevent that from ever becoming an attempt or unfortunately even a death. And that's what we want to do whenever possible. And then our do no harm prevention practices really talk about the appropriate use of prescribing practices and pain management techniques to prevent persons from becoming opiate or other medication dependent when there were other options for that person in order to prevent, again, developing persons with a dependency that then needs to be treated and has all kinds of negative outcomes upon their life. And one of the things that we know is that the mind and body are connected. We are all one holistic person, and our brain affects our physical health, and our physical health affects our brain. We know through studies that there's strong correlations between depression and anxiety to diseases such as asthma, cardiovascular disease, and diabetes. And so these really can't be treated in isolation. Yes, you could physically treat diabetes, but if you're not treating the depression that exists, you're not going to have as successful an outcome as you could if you addressed both of those issues, which are interacting with each other to keep both of those from becoming in recovery. Anxiety boosts the risk for stroke and high blood pressure. Prolonged substance abuse can lead to heart disease, cancer, hypertension, pneumonia, and other illnesses. And to ignore one in favor of the other does not make any sense. What we do know when we look at data, both in Oklahoma and nationwide, is that persons with mental health and addiction issues die much younger than the general population. And many of the reasons that they are, and I say this, I mean untreated mental health and addiction disorders, is because those untreated disorders are wreaking havoc upon the body as well. It's wreaking havoc on the heart, on the blood pressure, on their blood sugar, on their breathing. And when we look at our data that comes into the Department of Mental Health, it is astonishing the people that we see who have severe mental illness or severe addiction disorders that they're starting to enter treatment in, and to see the deaths happen. One of the things I used to do, I'm getting a little older for this now, but I would look at the age of death that someone died that would come across in our system, and it was the majority of the time it's below 50. I would look to see, are they younger than me? But the majority of the time it's below 50, and they're not dying from things like suicide. They're dying from these other health issues that are aggravated or brought on by these behavioral health conditions. Primary care and ER settings have a great opportunity to identify mental illness and addiction issues and the chance to intervene. And you know, there has been a lot of talk, and I just want to reiterate it, about the number of people who die by suicide who have seen a medical practitioner in that month. And something happened to where either the questions were not asked, it was not addressed, there was not a referral made. And I feel like that is an area that we can really invest time and energy into to really help lower the high suicide rates that we have in Oklahoma. So we have, as an agency, partnered with healthcare agencies in these areas to really develop a flow of how that can be incorporated into the normal workflow that offices have, so that we are not missing opportunities to intervene and provide persons with the best opportunity for their best life. One of the things that's incredibly important too is care transitions. So if you think about an ER visit, and one of the things that has really stood out to me is if you have an ER visit for an overdose, or whether it be an accidental overdose, say an opiate overdose, well, that is a perfect opportunity for us to grab hold of that person and to provide them with the resources of how to get in recovery from that addiction. And as a state, we have continued to work on that, both for overdose and suicide, but we've got to do a better job. And we really have to continue to partner together and be creative and put the resources forward that we need to make a huge difference in those areas. Only 29% of people who died in the past year were seen in an outpatient behavioral health setting. So one of the things that I think a lot of people think of is that people who die by suicide are people who are involved in treatment and care. And actually, it's just the opposite. People who are involved in treatment and care are much less likely to die by suicide. It's folks that are perhaps touching other systems, but they're not ever getting engaged in outpatient care. And that is really the key to preventing deaths of that population. And people who die by suicide are more likely to have seen a PCP in the previous month than they are any other healthcare provider. So primary care practices can play such a key role in the prevention of suicide. And 83% of persons who die by suicide have seen a healthcare provider in the year before their death. So I think it really pushes the point that we have to work as a holistic system, that wherever people are seen, that we are asking about, that we are screening for these different disorders and for the risks that can come with them, and make sure that we're connecting people with care. So we'll talk a few minutes about opiate disorders. As you all are well aware, we had a huge surge in persons who became addicted to opiates, mostly in part due to the aggressive marketing and really underhanded tactics of the pharmaceutical companies. And as a result of that, Oklahoma in particular saw really high rates of persons becoming addicted. The good news is that we've made some really great strides in Oklahoma around that. I'm so proud of all the work that has been done in Oklahoma from everyone to really get this epidemic under control. So one of the things that's important about opiate disorders is really to identify those problems as early as possible and link them to care. There's great evidence-based care for persons who have opiate disorders, and we have it available in Oklahoma, but we truly have to get persons to those services. Universal screening, intervention, and referral for treatment for opiates is incredibly important in our healthcare settings. There's a lot of research around medication-assisted treatment for opiate addictions. In fact, we do know that persons who become in recovery from opiates by using, as part of their treatment protocol, medication-assisted treatment, have better long-term outcomes, have less results of opiate overdose deaths in the future, and they stay in recovery and lead long, healthy lives. Now, it took a while for people to put their mind around that. You would hear things about, well, you're trading one drug for another. Fortunately, most of that stigma has dropped away. And what we see is that persons really can benefit from the various types of medication-assisted treatment, and it has wonderful outcomes. And so one thing is really to have an understanding of the importance of this type of treatment and increase the number of providers, including nurse practitioners, physicians, physician assistants who are able and willing to provide MAT. Now, we have MAT available across the state through our network of treatment providers, but there is something that is really stigma reducing about going in to see your own primary care physician who screens and identifies that you have an opiate use disorder. And they are waiver trained and can provide that care and treatment for you right there in your primary care practitioner's office. It really normalizes the fact that these are diseases and disorders just like physical care disorders, and that they can be treated and treatment is available. And my own physician understands enough about these to be able to assess me for them and identify and sometimes even treat. We've done a lot of work about integrated care models, both where primary care physicians may be doing MAT, but we will partner in doing the counseling that we know is evidence-based practice to go with that MAT. And we've also done a lot of work around pregnant and postpartum women who have opiate use disorders, how to move them into recovery, how we can help them raise those children with the very best outcomes possible. We have what is called the STAR Clinic, and it serves pregnant and postpartum women with substance use disorders and opiate use disorders, and their substance-exposed infants. I'm really proud of this work that has been done. It was launched in November of 2019, and it provides all the medical, prenatal, and postpartum care, as well as education, case management, therapies, development of a prenatal plan of safe care, medication-assisted treatment services, types of recovery services and supports. This has been a partnership with Children's Hospital at OU Medicine and the department and DHS, as well as our treatment, referral, and support agencies and organizations. And we're seeing really life-changing things come out of this partnership. So we have MAT services available statewide. You can walk into any community mental health center, any of our CCARCs across the state, and have MAT services available. We do a lot of that work through telemedicine. That works great. Our community coalitions have directly engaged over 52,000 Oklahomans and made 10,000 referrals to treatment and overdose prevention services, which is just phenomenal. And one of the things that I want to point out as we go through these things about opiate use and abuse is that our state has really done a phenomenal job, and we have seen large declines in opiate overdose deaths in Oklahoma. We've seen declines in the prescribing of opiates, and we have seen increases in the number of persons entering treatment for those diseases and becoming in recovery from those disorders. We also have over 850 residential substance abuse treatment beds that can provide higher levels of care for addiction disorders if needed. So we use the American Society of Addiction Medicine criteria when we assess someone. So many people can be treated on an outpatient basis, but there are certain needs that a person may have that makes them a better fit for residential substance abuse treatment. For as long as I can remember in our state, we had a very long waiting list for that level of care. And there was nothing more frustrating than to have someone present who is at a point in time where they want and are reaching out for services, identifying that the best level of care for that person is substance abuse treatment in a residential setting, and have to place that person on a waiting list to receive that care. Now, don't get me wrong, we're going to provide outpatient care in the interim, but we know that what is really needed is residential for that person. And I can remember a couple of years ago where if you were a male in Oklahoma and you were assessed for needing that level of care, then it was going to be at least 3 months before your name came up to have a bed available. And can you imagine the types of things that would happen to an individual when they have to wait that period of time and they are at their worst? It's no wonder that we have high rates of incarceration, high rates of people going to jail, high rates of overdose deaths that were resulting from that. We were fortunate enough to be able to expand our residential substance abuse treatment beds about 1.5 years ago, and we have been rapidly building those up. And now we don't have a waiting list. If you are assessed for that need, we can get you into a bed. It's interesting, about the time that we got to our capacity need, COVID hit, and people were much less likely to want to go into a residential setting because of the risk of infection. However, we still treat many people in residential every day. That is continuing to grow, and we do have availability for persons who are needing that. We were able to do away with our wait list, and now when you go and have an assessment, then in real time you can receive a bed. We've had beds added in Enid, Tulsa, Valiant, Grove, Lawton, and throughout the state. We have a number of different types of technology that we've been able to add around treatment and recovery in our state. We have e-intervention, which connects the community to get individuals into treatment and facilitate care transitions. We have e-therapy, CBT that people can utilize on an e-therapy basis to teach patients about coping skills for their recovery success. E-recovery is another connections app. So we use a great deal of technology in the world of behavioral health anymore in terms of being able to connect people, to engage them, to help them receive care and treatment. Fortunately, we were doing that before COVID, so we had a really good infrastructure in place. And then with the advent of COVID, we just built upon that tremendously. And our technology use for providing services increased by 173%, if I remember that statistic correctly. Our network of care is an addition that we have made to our website. And basically it helps you find care and treatment either for yourself or for someone else. And it has a comprehensive directory designed to help people identify their local programs and resources and make informed choices about those. It provides information about the services, legislation, insurance programs and laws, support and advocacy, message board, social networking, housing, legal assistance, and much more. So when you go to our Oklahoma Network of Care.org site, there is a wealth of information, everything from a legislative tracking component that will show you what bills are in process that may have a connection to mental health and addiction issues. Again, it will tell you about the treatment resources. It will give you, there's quizzes and calculators to help you manage and decide whether you need to reach out or what kind of issues may be going on. A wealth of information about medications, symptoms. It's really an exciting addition, as well as there's a library filled with thousands of articles and fact sheets to inform you about behavioral health care. So I would encourage any and everyone to use this resource. It is something new to us that we've been able to implement this current year, and I hope that you will find it a valuable resource. And with that, I just wanted to kind of give you some of the information about our website, our Facebook page, our Twitter information, the okimready.org website, where you can see information around the types of things that we're doing around opiate addiction. And I just really thank you for the time to be able to share those things with you. And I am happy to answer any questions that anyone may have.
Thank you so much, Commissioner. Again, this is Dr. Steve Crawford. I'm hosting this particular seminar, and we really appreciate that wonderful information that you were able to give us.
If you'll hold on 1 second, I'm going to make the lights come on in here while you're talking, Dr. Crawford.
Okay, I see that the lights went off on you again. The challenges of technology.
Yes.
I want to encourage everyone to use the chat function if you do have questions for the commissioner. I do have one question at the moment, and I have my own, but the first is, can a person with or without healthcare insurance receive personal care from a behavioral health professional who provides continuity of behavioral health care for that patient?
So if I'm understanding the question correctly, yes. Now, as a state, part of what we do is we invest resources into providing care and treatment for people who otherwise would not be able to receive it because they have no ability to pay for it. So we have a full continuum of care for persons who really are without a means to access care. In addition to that, we also want to make sure that people who are underinsured have that availability as well. So if it's somebody whose deductible is too high or they don't have coverage for what exactly their need is, we want to make sure that they're able to get the care and treatment that they need. And yes, we have, one of our goals is to make sure we have a full continuum of care. And we have many providers that within that provider network, agency itself, they have the full continuum of care.
Wonderful. Well, we appreciate that. Another question I had was, with the advent of medical marijuana, have you seen changes in the mental health environment, as it were, for both substance use and mental health disorders in our state? And what can primary care do about that?
Well, that is a good question. And I would say at this point in time, I would not say that, well, there's a couple of things. One, first and foremost, I would say that there were a lot of persons in Oklahoma who already used marijuana. And so that was something that we saw within our system continually and still see. I don't think we've seen any large increases at this point in time. Where we have seen some increases and where our biggest concerns have been is around youth. And that we know that when something is more widely available and seen as less risky, that youth are more likely to take up that behavior. And that's especially problematic in a developing brain, because we do know that marijuana affects that developing brain. And we are starting to see signs of increased use in youth within Oklahoma. And that is something we really don't want to see. We want to keep those brains healthy. We want to let them develop to their full potential. And that is a concern. I would say on the adult side, I have not seen a large difference in terms of persons coming in for care and treatment around marijuana more than there was before. But that could be because we are overshadowed in Oklahoma by some other substances. Our number one drug that we see people seeking treatment for in Oklahoma is methamphetamine. And it continues to rise every year. And in fact, our overdose deaths in our state now, methamphetamine crossed opiate overdose deaths and is just continuing to climb rapidly. So it's almost as if most other substance issues, while there may be some ebbs and flows, and of course, opiate addiction was a huge one, and we've done a really good job of pushing that down, but methamphetamine is just roaring in our state. It's easily available, it is inexpensive, and it is a devastating substance, and that is our number one drug of choice that we see.
That's sad to hear. We don't have a medication-assisted therapy for that, do we?
We do not. I know that on the research side, people have been working and trying and examining, but as of yet, we do not have medication-assisted treatment for that. What we often do is we end up treating a person for severe psychotic symptoms, because that often comes out of being a chronic user of methamphetamine or even an acute user of methamphetamine. So we try to get people some sleep. We try to treat that psychosis and bring them back down to a state where we can start working with them. Unfortunately, one of the things that I've seen through my experience is that as a person continues to chronically use methamphetamine, that baseline that you can get them back down to deteriorates over time until there are points in time where they have done so much damage to their brain that that baseline has moved now. It is such a really tragic substance.
We have one other question and then we'll move on to our next speakers, but a clinician writes, we are a primary care clinic, and if we have a patient come in that scores 22 on the PHQ-9 and they have thoughts of harming themselves, where do we refer them for help? This is unfortunately a common occurrence in our clinic.
Yes. So I think I'm going to give you another long answer. First, what I would want you to do prior to that person coming in is to identify what the resources are there in your community. And you can do that from your website, or honestly, you can call us and we will help you with that. And then I'd like to see some development of a relationship between you and those local resources. And again, we can help you with that too. So that when you have that experience, you can pick up the phone and call someone at your local provider network and say, hey, can you help me with this? And then there's a number of things that can go on from there. One is we can work with you to help you better to know the evidence base around screening that person, to help you know if there's an impact or not. Or we can simply make sure that you have a smooth, good transition for that person into care. There are many, many times when people have thoughts of suicide that at that point in time, they're not at imminent risk, but they are needing to get into care and make sure that that transition takes place. So that's what I would love to see happen, is to develop a relationship with your local provider so that y'all can easily have those smooth handoffs. And if you need any help with that, we would be happy to assist.
Wonderful. Well, thank you so much, Commissioner. I know that your life's busy right now leading that agency and all the wonderful things you're doing, but I really appreciate the opportunity. And that's a wonderful question to lead into our next presentation.
Thank you.
Thank you very much. I do want to let people know that, again, this is the conference or webinar on connecting Oklahomans to mental health services, best practices for mental health referrals. And I'm Dr. Steve Crawford, co-director of the Oklahoma Primary Healthcare Improvement Cooperative that's working conjointly with the Oklahoma Department of Mental Health and Substance Abuse Services to put on this particular conference. I do also want to let folks know that we, through a contract with our Department of Mental Health, have been actively involved in some of the education that the Commissioner mentions on do no harm in regards to appropriate pain management and how to implement SBIRT within your practices. And if you have any interest in that, please don't hesitate to contact me, Dr. Steve Crawford. Our next speakers to talk on primary care referrals for specialty services are Drs. Brent Beasley and Daniel Duffy. Dr. Beasley is now the co-director of our Oklahoma Primary Healthcare Improvement Cooperative along with me, and he's joined today by Dr. Dan Duffy, who was one of the founders of our Oklahoma Primary Healthcare Improvement Cooperative and both have a long history of providing primary care in our state. They both are at the OU School of Community Medicine and Tulsa University School of Community Medicine in Tulsa. So if I will let Drs. Beasley and Duffy take it away, but remind everyone to use the chat function to ask any questions. Thank you.
Thanks a lot, Steve. Can you hear me okay, Steve?
Yep, sounding good, Brent.
Okay. So just as you were noting, I couldn't imagine on a golf course being teed up any better than what Carrie has provided for us. So with that, particularly with that last answer and the question that was asked. So let's look a little bit at the knowledge gap we're going to talk about here. We know Oklahoma primary care clinicians and their staffs may have insufficient knowledge and effective practice processes for referral of patients to behavioral health resources when patients screen positive for depression, suicidality, or substance use disorders. The current primary care and behavioral health care coordination in Oklahoma is fragmented, as she just talked to us about, and lacks facility of implementation. Next slide. In terms of the learning objectives we're going to talk about, we'll describe a clinical process for completing a referral and initiating co-management of behavioral health problems in primary care. We'll implement a primary care to behavioral health clinical process for referral and co-management in practice, including a referral directory, the specialist compacts, a primary care practitioner to behavioral health referral request, the behavioral health to primary care practitioner treatment report, and the patient consent to exchange information and co-management tracking. And we'll acknowledge the barriers in the current PCP to BH referral process in Oklahoma. Now, many practices currently employ screening for mental health issues and depression. We know that further from there, further stratification forms are being used sometimes in some practices to identify things like problem drinking, suicidality, eating disorders, and other mental health disorders. In a small number of screened patients, the risk score for either depression or alcohol drug abuse suggests the patient is at severe risk for immediate harm. The Expert OK program that OPHIC has organized prepares our clinicians and their staff to have a plan for quick referral of these patients to appropriate specialized services. Dan's going to walk us through the next slide.
Hi, this is Dan Duffy, and what we've done at OPHIC, when we began introducing Expert to about 60 practices around Oklahoma, we realized that one of the things that was going to be most important for these practices was to be able to develop a cadre of behavioral health or mental health specialists for referral. The biggest fear most primary care clinicians have in using the PHQ-9 to screen for depression is uncovering suicidality that is imminent. And what do we do? How do we handle that? And as a consequence, many clinicians have said, well, it's best that we not screen, then we don't have to deal with it. Well, Commissioner has told us there's very good reason not to do that. And we in primary care are in the ideal position to make a big difference. So what Brent and I did was actually help our practice facilitators who will come into your primary care practices and help you develop a practice workflow specifically for behavioral health referral. That's the topic of today's conference, but you'll see that this is a generic process for any referral, whether it be to cardiology or to surgery, gastroenterology. But it is perfectly, and is most important for the behavioral health referral because we are doing the screening through Expert for depression and substance use disorder. So for those of you not familiar with the swim lane approach to looking at a process, we have 4 different actors in this particular swim lane. One is the patient, one is the clinician who will initiate this particular process. And then we have a process here called e-communication and care coordination. And it may be the process that actually is the least familiar to many of us in primary care. And then we have the swim lane that represents the behavioral health specialist. Now, if you think about it for a minute, from a primary care perspective, we're usually not dealing with one community health center, but are going to be dealing with all 5 of those in urgent care, crisis center. We may be dealing with a group who provides group counseling or all kinds of services. And so we're not dealing with one behavioral health specialist like we may be with a gastroenterologist or a cardiologist, but actually multiple ones. So let's look at this. The clinician recognizes the need for referral. Ideally, that's come through the Expert process. They recommend a level of care for the patient, either counseling or a psychiatrist who will help him with medication management. The patient may resist. So one of the skills is that the clinician really needs to engage that patient in a conversation. That's where brief intervention comes in, and provide the patient education. Let's assume the patient agrees, and then the clinician completes a referral form to a behavioral health specialist. He and she, the clinician, with the patient selects an appropriate therapist, ideally one that's nearby and affordable to that particular patient. That sets up the entry of that referral into a referral tracking system, which many primary care practices don't have or have in a very rudimentary way. One of the practices I went into several months ago, I saw that the referral clerk in that office had sticky notes all over her computer screen, trying to keep track of were the referrals consummated or not. And that system contacts with the behavioral health specialist who accepts the referral and moves forward to make contact with the patient to schedule the visit. And I show you here this little box in the middle of the referral tracking process. If you have an electronic process that we'll talk about in it later, it actually tracks that this step occurred. The behavioral health specialist has a therapy visit, and the patient has visited the therapist, and that is also tracked for everybody in the electronic tracking system. The behavioral health specialist then reports back to the clinician, and a consultation exchange occurs where the primary care clinician and the behavioral health specialist may exchange information about the results of the treatment and the care that was given. Now, the commissioner was very clear in saying this needs to be a relationship, but what we're showing on this slide is in addition to the relationship between the primary care clinician and the behavioral health specialist, this communication of information that's transmitted electronically is really the only way to be doing reasonable referral work in 2020. And then we end up with the therapy visit having a note exchanged for both records. The PCP would have a visit and review with the patient what happened in the behavioral health visit, and we continue the cycle. So if there are any questions on that, we will be happy to answer them. Please ask them in the chat if you can. So Brent, you've had some experience in establishing these referral consultant relationships that the commissioner has talked to us about. You want to take over from here?
Sure, I have some, Dan. We strongly recommend establishing specialist and treatment agreements called compacts for receiving and sending referrals and co-managing patients. A compact is not a legal agreement. It's an understanding between the primary care practitioner and the specialist or referral services that are required. It helps to develop the communication skills and the tools such as the forms and the different computer applications that the office uses with patients and referral resources to assure smooth transitions and coordination of care. For instance, when I developed a compact with a specialist, we discussed whether I need consults where the specialist makes recommendations or a referral where the specialist actually carries out all of the orders and the prescriptions. Dan, you want to walk us through an effective referral system?
Sure thing, Brent. So what we suggest and what OPHIC will do is when we bring a practice facilitator into your primary care practice as a part of either the SBIRT project or any of the projects that require referral, is we help you or the leadership of your clinic designate a referral or co-management coordinator. And this may be somebody already identified in the practice, but if not, it's a role in the primary care practice that becomes very important in establishing this referral system. Now, there are several steps that this coordinator will work on. One is developing a behavioral health referral directory of the services that are needed, the insurance that that particular service takes, and the limitations. Do they have any restrictions? Some of the tribal clinics, for instance, only will or have the capacity to take tribal members. And what is the contact information? This referral directory becomes an invaluable resource at the time of a busy primary care practice where the clinician wants to get the referral done, but that's not the time to begin looking up on the excellent Department of Mental Health website for the contact information for those specialists. Once we've identified from the various work that we'll look at who's in that referral directory, then we suggest that the referral co-management coordinator begin to facilitate the primary care practice behavioral health compact. And there are 4 areas in the compact that we think are important. One is the transitioning of care. How do the two agree to exchange information and get the patient to the behavioral health specialist and get information back from the behavioral health specialist to the primary care physician? That is the most frustrating part of this process for the primary care physician, who feels like they're completely out of the loop in a person that they're providing a lot of care for in every other area. How do you get access to care? How do you collaborate on care? Who is going to do what? Who's going to write the prescription for the antidepressant and monitor the effects? Who is going to order tests? Who's going to communicate to the patient the progress that they're having? And then that communicating to the patient will both agree, both the primary care clinician and the specialist agree that they are going to have a respectful approach for communicating with patients, which takes the patient's views into mind. So
Dan, may I add one thing? Yeah, I was just going to say one thing that a lot of the people on this conference may realize and be saying to themselves is, I've never seen that happen before. It is a very rare thing to see a compact set up between a primary care office and a specialist. We do think it's a best practice, and we actually think that these the communication is going to be improved when our practitioners actually reach out in person, not sending their referral coordinator, not sending a nurse, but reach out in person. Let's have lunch. Let's talk about this.
Right on. Right. In fact, bringing lunch to the meeting makes a really good impression on everybody. There are 3 forms we'll look at that are just tools to get this thing done. One is a behavioral referral form from the primary care practice. You probably already have referral forms in place. We are really promoting and helping you get these forms into either the electronic health record or into a referral tracking process that gets the appropriate information to the behavioral health specialist. The second one is a behavioral health consultation communication form back to the PCP. This is one we've already said often fails in this particular process. And then lastly is a patient release of information form. Remember, and the behavioral health people on the call know full well that the HIPAA requirements for substance use disorder and for mental health conditions is more stringent than the HIPAA requirements for other exchange of information. The last piece, so we have the directory and the compact forms that we'll build, is to build a referral tracking system that can be used as a tool for care management. So here's the workflow, and I'm not going to go into as much detail on this one as I did on the initial one, but we do have the administration of the clinic that needs some approvals on this. We have the referral coordinator assembling that directory, arranging for the behavioral compact meetings, as Dr. Beasley said, between both clinicians, training everybody on how to enter the data in the EHR, implement a referral tracking tool, implement co-management and care coordination processes. And lastly, the care coordinator generates some process outcome measures about the effectiveness of the referral process. The PCP clinician and the behavioral health clinician have this face-to-face meeting to agree on the compact and the form and the process. They both need training in how to use their electronic record and the tracking tool and how to communicate with each other using whatever tools are needed, and to provide the to receive performance feedback on the rates of our completing all of the steps in the referral process. Again, this is not something, well, any practice can use these this suggestion in implementing a system, but at OPHIC, our practice facilitators will help your practice put this into place. So here's an example of of the items that are in a referral directory. The Department of Mental Health provides a name of the practice site, what services they provide, what is the location, do they have face-to-face or telemedicine visits, what kind of insurance do they take, is there a limitation, is pre-authorization required, that's usually an insurance issue, is there a copay and what's that expected to be, and do we have a compact for it. The coordinator develops the behavioral health referral directory. Now, most practices are not going to have more than half a dozen or even 10 various resources in their referral directory, even though there may be hundreds available in the county or the community. Sadly, in Oklahoma, that's not very frequent outside of Tulsa or Oklahoma County. And the number of resources available are very few and may be distant. We identify the insurance coverage and then begin about developing the referral compact. This is just our other items that might be listed in the referral directory. Here are a number of, we have here outpatient mental health services. Here's a comprehensive mental health clinic, its address, and so on. These are the items that you may want to fill in your directory. The commissioner has already told us that we have mental health treatments available that are available from the Oklahoma Department of Mental Health and Substance Abuse Services. These are behavioral health services provided through the network of community mental health centers, outpatient mental health clinics, programs for the Assertive Community Treatment, the PAC project, community residential mental health centers, and then we have the panoply of addiction treatments. Brett, I'll turn it back to you, I think.
Okay, next slide. So the law actually exempts licensed physicians, psychologists, social workers, certified alcohol and drug abuse counselors, and individual members of the clergy in private practice from DMH certification process. Individuals, behavioral health groups, and agencies contract directly with the payers, OCA, DMH, private insurance. And we recommend using treatment locators, going to provider websites, and calling to inquire about site-specific services and insurance. You know, during this project, we've been looking online for where are all those located and where are they listed. And we've been impressed to find several different things that we didn't know were out there when we started. You want to put up the next slide there, Dan? So practices and the practice facilitators, and for those on the call who aren't aware, when we say practice facilitator, what we're talking about, within OPHIC, we have quality improvement specialists who actually go and work with the individual clinicians and their practices to implement the different quality improvement initiatives that we're speaking about. So anytime you hear us talk about practice facilitators, that's what we're talking about. So practices and practice facilitators can use, this was a surprise to us, Psychology Today, to identify therapists and psychiatrists in their area. And you can see when you get your slide deck after this, you can go to those websites and explore at the Psychology Today the different therapists that might be located in the Oklahoma area. Establishing a relationship through a compact before sending referrals to build stronger referral networks, we believe is a best practice. On that side, on the Psychology Today side, clinicians can register themselves and their credentials, and they're verified by Psychology Today. And the clinicians will detail if they have video or phone session options, the cost and the accepted insurance plans, and their specialty areas and the treatment approach. And you can filter your search by the issue you're looking at, whether it's alcohol, drug abuse, depression, the city or county you're in, the insurance provider, and the types of therapy and even the prices. So let's just show you just a real quick what the Psychology Today website looks like. So you can see there, you know, it's got Tricia Myers as the therapist who's the licensed professional counselor. It shows what she's interested in, the phone number, what counties that she is able to provide help in. Next slide.
And Brent, this is
Yep.
this check verified means that Psychology Today checked out that this is actually true, even though she entered it. We can rely on it.
Right. And then on the next slide, we see Tricia Meyer's actual qualifications, the number of years in practice, where she went to school, state boarded, that type of thing. So very helpful, I think, for all of our practices in trying to locate these type of mental health services. And the other thing is checking with licensing boards. So the clinician's license number is listed on the Psychology Today site and can be cross-checked with the appropriate licensing boards. And so we have a list there of the different licensing boards that you can look into as well. Anything else you wanted to say about that part, Dan?
Not at all, other than this is not a easy task. To really do a good job of this does require some elbow grease, and that's why we're so happy that the OPHIC practice facilitators will help practices get this in place so that they can keep this up.
Good. So let's talk a little bit. At OPHIC, as I said, we have our trained practice facilitators, specialists in quality improvement, working with our partnering practices. In this role, our practice facilitators help the practices assemble that referral database, although the practices will be putting in a lot of the elbow grease on that. But they're there to help identify behavioral health referral service location and contact information. They help identify the clinician's name and the credentials and the license type. They help identify specific behavioral health services provided by the office or the agency. They identify the insurance that's taken by the behavioral health service provider and the pre-authorization if that's required. The patient eligibility criteria are documented, as well as the estimated out-of-pocket expenses for the patient. And they'll assist the PCP to develop a PCP specialist compact or co-management plan and help identify the specialist quality of care score. So the barriers, Dan and I have looked and thought a little bit about this on the barriers to the co-management or the referral process, because I've been in practice for nigh on 25 more years, and Dan, at least that, right?
I'd say more than 50.
Things we've seen along the way. So clinician not identified or not having a personal relationship for the co-management. You know, sometimes an office, a specialist office, can be a nameless building. You're going to go to OHI or you're going to go to wherever. And so you don't really have a clinician that you're familiar with. And that can be tough, and it can be tough on patients not feeling certain about, as a primary care clinician, that I really know who I'm referring to. The other thing is the behavioral health professional training and approach may be unclear at some of the offices. And again, it's nice if we can establish that up front, so I'm not sending someone who's really wants to work with your patients on obesity, as opposed to that you're trying to find a place for substance abuse. Insurance and cost of the patient information might not be identified, and that can be frustrating when you've sent the patient already. I've seen that happen multiple times in my career. You send the patient, they didn't take their insurance, so you've got mud on your face about that. Pre-authorization, often not understood by the primary care practitioner, and it is a myriad maze that's difficult to sometimes navigate with the pre-authorization. Eligibility criteria for referral not being defined, and sometimes that's really up to us as the primary care clinicians. We really need to be specific when we're talking about what we're referring the patient for. Ease of documentation of communication for co-management. It's not easy when we have multiple EMRs out there. My EMR doesn't talk to your EMR, and so that seamless transfer of communication doesn't happen. I'm constantly calling offices or asking my nurses to call offices. Please send us the referral report. accessing the DMH license and contracted services, although Carrie showed us some ways that make that a little easier. And then accessing private behavioral health providers around the state can be sometimes difficult or onerous. Dan, you want to walk us through this next part?
This looks, let's see, I'm unmuted. Okay, so this looks really very complicated, and we're going to go quickly through this. These are just those forms we talked about. And here's an example of a compact document, which is the agreement. And again, it's not a legal agreement regarding co-management between the behavioral health specialist and the primary care physician. Brent and I have looked at these as kind of like an agenda for that lunch meeting that we're going to have with the behavioral health specialist and the primary care physician to just let us talk about this and see what our philosophy is and how we want to work together. So if we look at the transition of care document, we see that the compact defines the roles of the PCP and the behavioral health provider in assuring confidentiality. That's pretty straightforward, and providing the needed information to each other. I think we've now emphasized that 6 times, Brent, that this providing information back and forth is the only way we function like an integrated care team. The access agreement describes access for the patient and the PCP to the behavioral health provider, and reverse access to the PCP by the behavioral health provider. Both agree to provide both adequate visit availability for the patient and backup when they are unavailable. And again, if we're going to function as a integrated network or team, these become really important decisions. If we look at the collaborative care management, the PCP and the Behavioral Health Compact aims to provide collaborative care management, provide team care, and define the communication role of the teams to each other. We spell out the expectations for the contact that involves respectfully notifying the other when one makes a referral that might impact on the care provided by the other. This happens a bit in behavioral health areas where the behavioral health specialist has a very good reason referring the patient to a third person that the primary care physician doesn't know anything about it and ends up having egg on their face when the patient comes back and says, "Why did you send me to that other facility?" And again, we don't want to have that occur. And then lastly, the behavioral health clinician agrees to provide necessary education and guidelines and protocols for managing behavioral health problems within the scope of the primary care practice. You are the behavioral health folks are specialists who really need to make sure that the primary care clinician and the specialist are on the same page. The patient communication is discussed, and the contract describes who's going to tell what to the patient and to the family and respect their choices. Here's an example of a referral form. It has the patient identification. The PCP can spell out the patient goals for treatment that were discussed during the brief intervention. The PCP may have recommendations for the kind of treatment they think might be useful. This lets the behavioral health specialist know what the PCP clinician told the patient. So if they have a different idea, they can tailor their communication accordingly. A brief statement of the medical and psychological history that the PCP has, the current medications that may be affecting the treatment, and the PCP contact information. Some practices actually have the patient sign this referral form, indicating their consent to participate in the referral. Here's a brief example of a mental health to primary care clinician communication. Again, it has the practice and patient identification, diagnostic information, treatment and response, type of treatment, and any specific recommendations for the PCP. And lastly, here is an example of an authorization to release information from the behavioral health to the PCP clinician. It has the name, the specialist's name, the PCP's name, conditions and date of consent, patient signature, and a witness signature. And on the reverse side, it may have the reauthorization for a second year of exchange of information should that be needed. Lastly, we're going to briefly mention the referral management system. CASS from the health department or mental health department has a terrific tracking system, one that's available to members of the Sooner-HAN, which is the Sooner Health Access Network, provided by the Oklahoma Healthcare Authority. Actually has a no-cost store and forward telemedicine tool that's web-based, 24 hours a day, 7 days a week, bi-directional real-time communication that eliminates paper. You can attach image and medical records. It customizes work lists for comprehensive tracking, and it's a process that provides oversight and customizable analytics. So this is the one way that we know of to have a tool that provides you with feedback on the work of the referral process. Brent, I'll turn it back to you. You're on mute, Brent.
Yes, thanks. In summary, a usable referral and co-management system begins with a usable directory, and that's something that takes some time to develop. The co-management compact is that second piece between the primary care practitioner and the specialist that facilitates better communication. The primary care practitioner can initiate patient consent to permit exchange of information, and a referral tracking program facilitates that co-management with the whole team, the primary care clinician and the behavioral health therapist. So we've presented what we think is what we consider the best practice. We're open to questions you have about this. We do realize that you don't see this a lot in current practice, but we think that this is the way it ought to be done.
Steve, back to you.
Yes, thank you, Dr. Duffy and Dr. Beasley, for that wonderful review of referral management, particularly in behavioral health. I again would like to invite everyone who may have a question to put that in the chat function of the Zoom device or platform. I do actually, while we're awaiting any questions, and I do want to remind everyone that they will get a link, those that have attended, to this recorded webinar, and a copy of the slide decks that were used both by the commissioner and by Drs. Duffy and Beasley. The first question I have for you all, is there a cost to using doc-to-doc to the practitioners?
Yeah, I'll answer that. So anyone who is a member of the Sooner-HAN, that is, provides care to Sooner Choice patients, has free access to doc-to-doc because it is used in the Sooner-HAN to track all consultants and manage it. Beyond that, there is a fee and participation in the My Health Access Network is required in order to use doc-to-doc.
So with that, can it be used for non-Medicaid Sooner Care patients?
Absolutely. That's one of the agreements with Sooner Care, that in a practice who's using it for Sooner Care patients may use it for any patients that they see in their practice, and it would not be limited to the behavioral health specialist, but any specialist who's in the doc-to-doc network.
And if they're not already part of the SBIRT program with OPHIC or with the Do No Harm program that OPHIC participates, you mentioned the practice facilitation. How did they go ahead? How would they access that particular program?
Well, Steve, I think you can answer that question.
That was what I was going to say, Steve.
They can certainly contact me, and I think that's on our list. They can actually contact Charles Tryon, who's our project manager for all of our OPHIC programs, who's been helping us be the director for this particular webinar, and thank him for that. We do have some of our practice facilitators on, I've noticed, and appreciate their attendance at this meeting.
Steve, you might well mention that through the generous funding of the Department of Mental Health and Substance Abuse Services, we do have opportunities for both SBIRT and do no harm practices.
Yes, and that comes at no cost to the practices. I think that's the important thing that we want to mention is that those two programs, because they're getting funding and have assisted us to allow us to provide this, I think, a very valuable service to many practices around Oklahoma. And many have already taken advantage of it. And I believe it's been very powerful in helping them screen for mental health and substance use issues and to provide better pain management for their patients that they see.
Steve, may I also call out Takia Sierra, who is absolutely spectacular in providing much of the data that we used in this presentation.
Yes, thank you very much, Takia, and all of our colleagues through the Department of Mental Health and Substance Abuse Services.